Extract 1, questions 1 to 12. You hear a neurologist talking to a patient called Vincent Chung. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Vincent, I've got your referral notes from your GP, but I wonder if you could tell me in your own words how this all started, what treatment you've had, how that's gone, and anything else you think I should know.
Thank you, Doctor. Yes, well, it all started about 3 months ago. I was just washing one morning, and everything was completely normal, when suddenly I felt a pain go right across my face, for no apparent reason. Then, after that, the attacks came quite often. If I had to describe it, I'd say it's like a searing pain, and it usually hits the right side of my face. Like I said, it goes right across it, but it's my cheek, teeth, and my jaw that seem to take the brunt of it. It's a horrible feeling, too. It feels like an electric shock. I have to say, it leaves me feeling quite shaken.
And have you noticed any patterns or triggers? Is there anything that seems to bring this on?
Well, like I told you, the first time it happened, I was washing my face, but now I notice that brushing my teeth and shaving also bring it on. It seems to be anything to do with touching my face. I mean, even the wind can cause a sudden attack of pain. And also, just using my face or mouth can bring one on too. So, I mean, like, just eating and drinking can cause one, or smiling at something suddenly, or for a long time. Basically, anything fun, pleasurable, or necessary seems to cause me horrendous pain.
And do you think that the condition's developed or changed in any way since your first attack?
Oh, they're definitely happening more often. And not only that, it feels like they're affecting my whole face. At the beginning, the attacks probably only lasted about, what, 30 seconds or so? But nowadays, I find myself dealing with the really painful part of the attack for a few minutes at a time. And it's actually getting severe now. I used to be able to cope with the pain by clenching my fist or talking myself through it or whatever, but I can't now.
And I see here that your GP prescribed you some medication. Has that helped at all?
Well, I expect you can see on my notes what I'm on. My doctor was reluctant to give me anticonvulsants at first because apparently there are one or two that can cause serious reactions.
Yes.
But he found one that carried a very low risk, so I was on that for a time. Anyway, after a while, they started to lose their effect, so then he put me on antispasmodics. That's what I'm on now.
Mm-hmm.
I don't know if it's relevant, but I also take supplements, cod liver oil, and vitamin D.
Okay. How are the antispasmodics working out for you?
Well, I have to admit that when I take them, the pain is a bit more bearable, but they do affect me in other ways. I mean, I'm drowsy all the time. I can hardly keep my eyes open. And just trying to follow a conversation or remember what it is I'm supposed to be doing has become a challenge. It really doesn't take much to make me confused. I mean, it's embarrassing. So, to avoid people thinking I've completely lost it or whatever, I've ended up staying at home a lot of the time.
Oh dear.
Now, that's something I've never done, and I think it's that more than the pain which has led to some very strange mood swings. I mean, that's not really like me, Doctor.
I see. Well, from what you've been saying, it sounds like we need to book you in for some tests and explore the possibility.
Part A. You hear a specialist physician talking to a patient called Julie Dooley. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Your GP says you've been to see him about a lump in your breast. So, when did you first notice this lump?
10 days ago. I was doing my routine check when I was just so shocked to find it. It's in my left breast. I'm really worried because my mum died 6 months ago from breast cancer, and I've been scared of getting it ever since.
How old was your mum?
65.
Do you know if anyone else in your family has had it?
I don't believe anyone else has. I don't remember...
Mum,
65.
do you know if anyone else in your family has had it?
I don't believe anyone else has. I don't remember either of my parents talking about it affecting their own mums.
Are you married?
Yes, but we separated 9 months ago. He went off with another woman, and I'm on my own looking after my 2 children. I've got a girl who's 14 and a 12-year-old boy as well.
Have you ever been sick with anything serious before?
No, my health's always been very good.
I take it you're not on any medication then?
That's right, nothing. But there is something else that's been playing on my mind since I noticed the lump. I started remembering this pain I've been getting just here, in my chest. I never really thought anything of it before because it was kind of, I don't know, just very dull, like I'd pulled something, a muscle of some sort. So I really wasn't very worried about it. I just thought it would go away in time. But now, I don't know. Do you think it could be a sign of something?
That's difficult for me to say until I examine you and we run some tests. Is there anything else you can tell me?
About the pain? Well, it seems to go to my back. I usually only notice it when I'm sitting in a chair. Not a chair at the kitchen table. More like when I'm sitting in the lounge. You know, something with a high back on it. It did wake me from sleep once. It only lasted for about 15 to 20 minutes, but it was probably the worst I'd felt it. There hasn't been anything else really. Like I said before, I'm usually pretty healthy.
You haven't had any nausea or vomiting with it? No shortness of breath?
Nothing else except for what I mentioned. Oh, I do hope everything is all right.
Of course. Do you mind if I examine you now so I have an idea what we're dealing with?
No, that's fine.
Okay, there it is. Does that hurt?
No.
Right, it's quite solid, roughly 2 or 3 centimetres in length, I'd suggest. We'll need to run some tests to confirm exactly what it is. We can do those today, now actually, and then wait a few days for the results to come in. I'll need you to make a follow-up appointment on your way out today.
Okay, that sounds fine. I know I'm probably getting ahead of myself here, but if it is cancer, I really don't want to lose the breast. I'd hate to have a mastectomy. I dread that probably more than anything else. I really don't care what else happens, so long as I don't lose the breast. My mother had chemotherapy after she was diagnosed with cancer, and even though she lost all her hair, at least it grew back. I'd still be willing to try it.
Okay, well, you are jumping in a bit early here, but there may be options. First, let's run the test and wait for the results.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a nurse talking to a patient whose 6-month-old baby is having childhood immunizations. Now read the question.
Thank you for bringing him today. So, he's having the 6-in-1 vaccination, which will protect him against 6 very serious diseases: whooping cough, tetanus, polio, hepatitis B, diphtheria, and Haemophilus B. Now, before I go any further, I'd like to make it clear that there's no risk whatsoever of your baby contracting any of these diseases from the vaccination, as it doesn't contain any live organisms. You may notice a few side effects, which could make him feel a bit irritable for a few days afterwards. There might be a slight red swelling or small bump at the injection site, and his temperature might be slightly higher than usual. If he develops a fever, keep him cool by giving him cold drinks and removing any heavy clothing. You should contact the doctor immediately if his temperature goes above 39 degrees. This is the first of 3 doses he'll be getting to ensure strong immunity. Each dose increases his immune response, and he'll need all of them.
Okay.
Question 26. You hear a pharmacist talking to a customer about an emergency contraceptive. Now read the question.
You should take this as soon as possible. It might make you feel a little bit queasy, but if you're actually sick within 3 hours of taking it, you should go back to your doctor as you'll need another dose.
Oh, really? How likely is that? It doesn't usually take much to upset my stomach, and I'm about to start a long shift. There's no way my manager will let me off to see a doctor.
Well, if you're really worried, I can give you something over the counter, but you might still feel nauseous, and it'll probably make you a bit drowsy.
Oh, it doesn't matter. I'll just have a coffee and take it easy. I can't risk throwing up, though. I don't want to have to take more time off for another appointment. It's really inconvenient.
Question 27. You hear a practice manager talking to a physiotherapist who's about to carry out a home visit. Now read the question.
Mrs. Rumble hasn't come to any of her appointments so far, and we're not quite sure why. She needs acute therapy after her knee replacement, and we can't have her missing them. Anyway, we've agreed for her to have a few home visits first, and then, hopefully, after a while, she'll feel more positive about coming in. While you're there, maybe you can check her reasons for not wanting to come to the practice. Oh, and give her daughter a quick ring first to make sure they're both expecting you. There have been a lot of misunderstandings with these appointments. She also needs to sign these forms. If you could help her check the information's correct, I've already filled them out for her, but she needs to sign the bottom. When she's done them, can you bring them back here and give them to the receptionist?
Question 28. You hear an occupational therapist talking to a patient who's recently suffered a stroke. Now read the question.
So today we're going to be looking at how to improve your upper arm strength, and I'm also going to show you some exercises which will help you increase the dexterity in your hands. Is there anything in particular that's causing you concern or discomfort?
Well, my left hand is the main problem. I feel like I can't rely on it. It's all weak and wobbly, and sometimes it suddenly goes floppy, or the muscles will go tight and start twitching and shaking about all on their own. There's nothing I can do about it. I can't grip things properly either, and of course I need the other hand for my walking stick. I really don't want to end up having an accident because I've not been able to pick up a cup of tea or hold on properly to a stair rail or something like that.
Question 29. You hear a GP talking to a patient at a community practice. Now read the question.
So I understand that my 15-year-old daughter came to see you a few days ago. I don't want to snoop or betray her trust, but I would like to know what the rules or laws in England are regarding confidentiality. I mean, surely as her parent, I'm allowed to know what's going on.
Well, under 16s are entitled to come and see us in confidence if they're believed to be competent enough to fully understand the situation. We don't disclose information, even if it's extremely sensitive, unless there's a grave risk of serious harm.
But how am I supposed to look after her properly if she's really sick and hiding it from me for some reason? I'm not happy about this at all. I wonder why she's not telling me.
We would always encourage a young adult to discuss issues with their parents, but in extreme cases, yes, the law does require us to report information in order to protect the patient.
Question 30. You hear a senior nurse talking to the staff at a care home about the use of hoists. Now read the question.
As you can see, we have hoists in all the bathrooms. They are complicated to use and potentially dangerous, so in order to avoid injuries, falls, or any distress to patients, the correct protocol must be followed at all times when using this equipment. It's absolutely vital that a handling plan is completed for all patients who need to be moved using this type of equipment. It should detail all of the specific requirements, and by that I mean type of hoist, technique, number of trained handlers required, sling attachment loops to be used, and, where applicable, leg configurations. Everybody should go through this checklist with another member of staff every single time before using one, and nobody is to use one if they haven't attended the relevant course.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear a healthcare practitioner talking about aspects of their work. For questions 31 to 42, choose answer A, B or C, which you think best fits according to what you hear. Extract 1. Questions 31 to 36. You hear dietitian Catherine Weston delivering a presentation on diabulimia. You now have 90 seconds to read questions 31 to 36.
Hello, my name is Catherine Weston and I'm a dietitian with a keen interest in a little-known condition called diabulimia. The name is derived from a mixture of diabetes and bulimia, as it describes the situation where type 1 diabetics develop the behavioral characteristics of the aforementioned eating disorder. As insulin restriction is a significantly more dangerous act than calorie purging, the sooner something can be done about the countless lives being lost because of diabulimia, the better. To put things in context, it is estimated that approximately 400,000 people in the UK are living with T1. Whilst the exact number of people living with diabulimia is unknown, alarmingly up to 40% of sufferers, who are mainly female, aren't taking enough insulin to survive. With that acknowledged, it would be remiss not to mention that those affected are not exclusively women. A recent German study suggests that 11.2% of boys aged 19 and under are intentionally depriving themselves of insulin in a drive to be thin. Yet, despite the widespread reach of this condition, it is not as visible as other similar disorders, such as anorexia or bulimia nervosa. Part of the reason the condition is so low profile is the fact that the condition is not a recognized medical or psychiatric term, but rather it highlights the practice of reducing or eliminating insulin in a bid to lose weight. As diabetes sufferers cannot produce insulin but need it in order to survive, the practice of restricting their intake with the aim of losing weight is incredibly dangerous. Sufferers run incredibly high blood sugars, which has the potential to produce multiple irreversible diabetic complications. This can include neuronal, retinal and renal damage. The most common symptoms of the disease include irritability, decreased concentration and motivation, and diabetic ketoacidosis, all of which are analogous to diabetes. Rather eerily, by making the decision to cease treatment, sufferers are essentially turning the clock back on their condition. I do a lot of work with Diabetes UK in order to raise awareness of the signs and signals of diabulimia with friends and family of people with insulin-dependent diabetes mellitus. This type of outreach work was sparked by the many case studies of young people whose lives have been claimed by the disease. One such account is of the life of Amara, a 27-year-old who took her life after battling with the disease. Typically of people with the condition, Amara developed an unhealthy preoccupation with food. She also became increasingly uncomfortable taking her daily medication, comparing injecting her insulin to injecting fat into her body. Her sporadic insulin restriction then became a greater feature of her life. The unhealthy obsession with her diet led her to the discovery that despite not lowering her food intake, because she had drastically reduced her medication, she was losing weight. The weight loss is a result of the body cells failing to absorb blood sugar, with the consequence of prolonged elevated blood sugar in the individual. This causes the organs to be saturated in glucose. Amara was found dead, having taken her life after a futile years-long struggle with diabetes. Her death highlights the crisis for the medical and diabetic communities, neither of which have the resources or systems of care in place to support such a nuanced disease. In fact, such tragic consequences are so severe and such stories are so tragic that early detection is a governmental priority. NHS England's clinical team have been involved in producing the NICE guidelines on eating disorders, devoting part of the report to managing people suffering from an eating disorder and diabetes concurrently. The guidelines have been distributed nationally in a bid to tackle the illness. Furthermore, the organisation is integrating psychological services with GP practices by placing 3,000 new mental health therapists and surgeries. In addition, other private and charitable organisations are also keen to play their part. A prominent example includes Jacqueline Allen, founder of national charity Diabetics with Eating Disorders. Allen is presently campaigning for the omission of insulin for weight loss purposes to be recognised as a mental illness. The theory is that increasing the condition's visibility, it will become easier to engage multidisciplinary teams, including endocrinologists, mental health professionals and specialists like myself who specialise in the condition, to provide a 360-degree treatment service. Until that is achieved, however, the road to medical and psychological recognition continues.
Now, look at Extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on ankle fractures. You have 90 seconds to read questions 37 to 42.
Hello, Doctor. What are the types of ankle fractures?
There are different types of ankle fractures, and treatments vary significantly based on the location and severity of the injury. When a broken ankle occurs, the injury may be to the end of the medial malleolus, called tibia, or to the lateral malleolus, called or both. There are many types of ankle fractures, and let me explain you about certain common types ankle fractures. Lateral malleolus fractures is the ankle fracture that involves only fibula. Most of the lateral malleolus fractures can be treated without surgery if the ankle joint remains stable. A surgery is recommended in case of an unstable joint or the ligaments are damaged. However, the hint for surgical recommendation is when the fibular fracture is within 4 centimeters of the end of the bone. In such case, the fracture can be treated non-surgically if there is no injury on the inner part of the ankle. Medial malleolus fractures involves only tibia. This fracture occurs to the bone on the end of the tibia, which is called the medial malleolus. An isolated medial malleolus fracture is very rare compared with an isolated lateral malleolus fracture. Generally, a displaced medial malleolus fracture is treated with surgery. Bimalleolar ankle fractures involves both fibula and tibia that occur when there is an injury to both the inner and the outer side of the ankle, always resulting in an unstable ankle joint, and surgery is to be recommended for most of the patients with this kind of fracture. Even if the fracture heals without a perfect positioning, the ankle joint alignment will remain disturbed and could result in accelerated arthritis of the ankle. Even after a surgery, ankle cartilage can be damaged at the time of the fracture, resulting in arthritis. Therefore, a proper diagnosis and repair of these fractures is essential to avoid the chance of long-term problems. Although a bimalleolar equivalent fracture involves only fibula, there is also a tear of the ligaments on the inner side of the ankle, resulting in instability of the ankle joint. Therefore, a surgery is essential. Trimalleolar fracture involves both fibula and tibia like a bimalleolar ankle fracture. However, the bone in the back of the tibia called the posterior malleolus is also fractured. At times, if a large fragment of bone is fractured, a surgery is inevitable. Posterior malleolus fracture involves only tibia. This is a rare injury in isolation. Fractures of the posterior malleolus generally occur in association with bimalleolar ankle fractures. In such case, the injury is called a trimalleolar ankle fracture. Mesonerve fracture involves both fibula and tibia, which is a less common injury. However, this injury needs to be diagnosed thoroughly, as there are chances of missing this injury. In this type of fracture, the bone is injured on the inner side of the ankle, called the medial malleolus. The force of this injury passes through the large ligament that connects the two bones of the leg, called the syndesmosis. Since the damage is caused to this supporting ligament, the ankle becomes unstable, and most often a surgery is recommended.